addiction, including a study which he will be presenting today on psilocybin for cocaine use disorder. Peter also has an ongoing collaboration with researchers at Karolinska Institute looking at epidemiological data of psychedelic use. So what I really admire about Peter's work is that it's both scientifically rigorous and deeply human. He's really focused on how research can translate into real change in people's lives. He also serves as co-editor-in-chief of the journal Psychedelic Medicine, helping guide the field forward. So please join me in welcoming Dr. Peter Hendricks.
Thank you. I like these mushrooms. Can everybody hear me? Okay. Well, you'll have to forgive. Oh, here we go. Very simple design. Keep your expectations low, but I don't see colors too well. The term colorblind might be accurate, but I need blue background and bright yellow letters to see things here. I apologize if that's offensive. I wanted to share a little story before I started talking. My colleague Otto Simonson, who I think some of you might know, I'm curious. We have a small crowd, so raise your hand. Paul knows him, a few of you. But when I first came to Karolinska years ago, I'd mentioned to Otto, oh, you know what? Like many Americans, I have roots in Europe, and many roots in Europe, but one is a Swedish root. And there were a family known as the Westlings. I'm probably not pronouncing that correctly. I think Otto says Westling, who immigrated to the United States in the 1800s, though I don't know much about them. And since then, I've been to Stockholm many more times. This is my fourth time, and I've asked members of my family a little more about that story while that story is still there. And I learned that the Westlings left Sweden for the US in the midst of an awful alcohol epidemic in this country. I'm not sure how many of you are familiar with this. Again, show of hands maybe, but there was a disastrous alcohol epidemic in the 1800s where apparently the average adult, defined as someone older than 15, was drinking in a year 11 liters of alcohol, which by my calculations is nearly 20 drinks per week on average. And this alcohol epidemic really had disastrous public health consequences, impact not only on health indices, but crime and economic outcomes. And that led to millions of Swedes leaving their homeland for North America. So I often wonder about this, especially as we heard earlier, many mental health conditions are marked by a state of isolation. I think there is something to the notion that psychedelics could bring about a sense of connection or foster connection. I think that isolation is something that happens not only on the individual level, but on the societal level. And I think those Westlings left Sweden. It must have been very painful to leave the land they knew and the family they knew for a new place where they knew so little people and knew so little about the culture, to start a new life. And this was a consequence ultimately of an addiction epidemic that was ravaging this country. Now, I often wonder if those ancestors of mine who I know so little about, how they would react to know that I'm here now in Stockholm talking about psilocybin and the treatment of an addictive behavior, but I'm really happy to be here. Okay, so let me talk a little bit about cocaine. There have been some rather drastic increases in cocaine use during the COVID pandemic. There are 23 million users, or there were 23 million users worldwide in 2022, and fatal overdoses have been on the rise. Much of this is because fentanyl has ended up in the cocaine supply. And the rates of cocaine use are especially high in Europe, and Eastern Europe in particular, more so than in North America. So cocaine has become a big problem. In fact, you could argue it's never been as big of a problem as it is right now. But there are no effective pharmacotherapies. There have been dozens that have been tested, nothing that's been proven to work. And in fact, the only thing that we know works is contingency management with an odds ratio of 2.0, 2.1. And this is an intervention in which you essentially pay people not to use. Now, you might think of all the brilliant minds who've worked on treating cocaine use disorder that they might develop a better intervention than merely paying people not to use. Many have been tried, It's just that this seems to be the only thing that works. If someone provides you a clean urine drug screen, you pay them. The problem with that, there are a few, but one big problem is once you withdraw the payment, people tend to go back to using. And there are also other issues, including political support. Generally, people don't like the idea of paying people not to use cocaine. So contingency management has some limitations. So our own interest in pursuing psilocybin in the treatment of cocaine use disorder came from not only the fact that there are no approved pharmacotherapies, but relatively ineffective behavioral interventions, but also because much of the work that I do is in the criminal justice population. The US is something of a police state. We incarcerate more of our citizens than any country on the planet. And cocaine use is strongly connected with criminal behavior, risky sexual behavior, sexually transmitted infections. So it's a rather major public health issue. Very early on, I was interested to see if we could replicate to some degree Timothy Leary's Concord prison experiment and determine if we could prevent criminal recidivism with psilocybin. But my physician colleagues were quick to tell me that criminality is not the DSM. It's not an indication that we can pursue. So I've learned a lot about drug development. Our indication was cocaine use disorder because it's so strongly connected with these outcomes. So let me give you a brief overview of what we did. Now, I'm very glad that Guy gave his talk here about blinding and unmasking bias. That's something I'll return to here, but he's set the scene very nicely. So this was a quadruple blind randomized clinical trial. What do I mean by that? It means that everybody was blinded. The therapists were blinded, the assessors were blinded, the statisticians were blinded. Everybody was blinded. I guess the fourth would be the investigators. I served as the primary therapist on this trial and the principal investigator because we had a very small budget. That's what we had to do. But everybody who could be blinded was, and those who did the assessment were blinded and not involved in treatment in any way. So what we did before treatment even began was conduct a baseline assessment. Our main outcome was percentage of cocaine use days, or specifically percentage of cocaine abstinent days, the inverse of use. Okay, so at baseline we got a sense of people's use patterns in the past 90 days, and then we also wanted to see that they were capable of attending appointments before we began the psychotherapy. So we had what we called pre-screen appointments. Participants merely had to show to the lab, and at that time we also screened them for hypertension or anything that might obviously keep them from participating. If they came to those two appointments, we had a medical exam. We wanted our participants to be generally healthy, and after they were able to jump through these hoops, we then began the psychotherapy or the preparation sessions, which involved 4, sometimes up to 5 psychotherapy sessions that were client-centered and that generally followed what I would call the COMPASS model, the same model that I think has been used at Johns Hopkins for years, as well as a manualized cognitive behavioral therapy that was developed 30 years ago, validated in at least 2 studies, and that's really classic bread and butter CBT, not ACT. After those preparation sessions, we had 1 drug administration session in a comfortable living room-like environment in a clinical research unit, and our participants were randomized to receive either 25 milligrams per 70 kilograms of psilocybin or 100 milligrams of diphenhydramine. So that is an antihistamine found in the medication Benadryl. And we chose that not only because it's over-the-counter and inexpensive, but because its pharmacodynamics are similar in some ways to psilocybin. It lasts for about the same amount of time, and people would certainly be under the impression that they received an active drug with 100 milligrams, although not one that would mimic the subjective effects of psilocybin. That would be crazy if that were the case. Okay, 48 hours after drug administration, the so-called integration period begins, and then we had 4 additional follow-up sessions focusing primarily on insights that may have been gained during the psychedelic experience or the psilocybin experience, and continued cognitive behavioral therapy. There was a lot of therapy here involved, in part because this was the first study of its kind and we felt better to provide more than less. We certainly didn't want to leave anybody feeling like they had not been treated comprehensively, that we had not done everything that we could to help them get off on the right foot and achieve abstinence. 90 days after the end of treatment and 180 days after the end of treatment, we did assessments only. And I'll say also that our assessments were all verified with urine drug screens. So anytime we saw anybody, we were collecting urine, we were determining if there were cocaine metabolites in their urine, And generally, the way this would work is if somebody said they hadn't used, say, in the past week, but they were testing positive, we would highlight that outcome to them, ask them if they wanted to change their report. And the assessors were clear to communicate almost every time we saw a participant. The main objective of the study was to get the most accurate data that we could, that there were no expectations on our part other than they answer as honestly as possible, and that we wouldn't be disappointed or happy one way or the other, that we just wanted that objective data. This process seemed to work quite well. We had some discordant urine drug screens before drug administration, but we had no discordant drug screens after. So as far as we can tell, people were telling us the truth. So a bit about the demographics of our sample. The main thing I want you to take from this, most of our participants were African American or black. The city of Birmingham, the population is 72% black. The sample here was 82.5. I think that is representative of the population of cocaine users in Birmingham, Alabama. You'll also see that this was a lower socioeconomic status sample. Most made less than $30,000 per year. In fact, 62% made less than $20,000 per year. And then at the very bottom, I want you to note, if you can see that very few had ever used a psychedelic before. 2 people in the psilocybin group and 1 in the placebo group. And I can tell you, of those 3 people, 2 were men in their 60s who vaguely remembered having used a psychedelic when they were teenagers in the 1970s. So I would argue there wasn't much frame of reference. And when I asked them what those experiences were like, they would have said, I don't really remember. I think my friends and I got together, listened to music, and laughed. So I first want to show you our adverse events. And I'll just note, everything here was expected, it was resolved, it was transient. The only outcome that was not expected was a spontaneous orgasm. Some of you have laughed, I'm glad. I thought it was funny too. I didn't even really think of it at first as an adverse event. Fortunately, I have some wonderful physician colleagues who've worked in drug development and noted that still should be documented. I will tell you that the participant was generally happy with this outcome. But I could see how it might speak to abuse potential if that happened all the time. I'm sure that would be a drug people would want to use. But for the most part, what happened was expected, was resolved, was transient, and there were no serious adverse events. I want to show you a little bit about process variables too. I didn't want to put a consort flowchart on the screen. It was just too much to process at once. But one thing I do want to point out here, of the 20 people who were administered psilocybin, none terminated treatment early. But of those who were administered the placebo, 5 of the 20 requested to terminate treatment early. So during that integration phase or the follow-up phase, they essentially said, I don't want to be in this treatment portion of the study anymore. Of course, as an intent to treat study, we did everything we could to keep them as participants and to obtain follow-up data, and we were able to obtain quite a bit. With few people lost to follow-up. But importantly, because treatment retention is such an important issue with cocaine use disorder, I do want to point out that in the psilocybin condition, we appear to have done a very good job. Everyone was retained. That was not the case with placebo. Okay, so Guy talked about this a bit. We asked participants to guess within 48 hours after their drug session whether they received the active drug, psilocybin, or placebo. You'll see that of the 20 who received psilocybin, 18 correctly guessed they got psilocybin. Okay, no surprise there. But importantly, of those who received placebo, there were actually more who thought they received the psilocybin than the placebo. You might say that our placebo functioned fairly well. People were not really able to determine any better than chance that they received a placebo. And my general impression in the literature is, if you have a believable placebo, then your drug treatment difference will not be inflated. I think this is important. So in general, those who received the placebo didn't quite know. Maybe it was a flip of a coin, but they were more likely to guess that they had received the active drug. How about the therapist treatment guess? Okay. So what you will see here is the primary therapist, that was me, I guessed correctly 39 out of 40 times. The secondary therapists would have been graduate students or residents, psychiatry residents, also guessed quite accurately. For me, there was one person who got psilocybin, who I thought received placebo. I'll talk about that participant again in just a bit. And for the secondary therapist, there was, as you can see, one person who received the placebo who the secondary therapist thought received psilocybin. So we're not perfect, but close to it. Okay, so you've probably seen some of these subjective effect measures. This was the challenging experience questionnaire. There was a difference between conditions, so those who received psilocybin were more likely to endorse these challenging experiences, but if you can see, there are adjectival anchors associated with each of these numbers, and even for grief, which from what I can tell had the largest mean score, participants were saying that their experience was just below slight. Now, I do think this is interesting because we're asking people to determine how difficult their experience was at the conclusion of the 4 to 6 hour long experience. And I would imagine that some people have a way of minimizing how difficult it may have felt in the moment. I would suspect that if we had some kind of ecological momentary assessment, people might endorse stronger ratings. But still, one takeaway is that at the end of the day, our participants were not necessarily reporting that these were extremely difficult experiences. Let's look at the mystical experience questionnaire, which uses the same scale, the same adjectival anchors. And here you can see a pretty robust difference between the conditions. These effect sizes are all quite large. And for the most part, people were endorsing that the mystical nature of this experience was somewhere between strong or extremely strong. And I think this is notable because many of these questionnaires were written by religious professionals or religious studies professionals with PhDs, and our participants were certainly not reading at the college level. The average reading level may have been 4th or 5th grade. And some of the items I noted with these questionnaires are very esoteric and abstract. That our participants could complete them, I think, reliably was impressive to me, because often I feel like these questionnaires require a PhD just to interpret. Okay. Guy mentioned this as well. So we asked people using the Hopkins questionnaire to rate the spiritual significance of that psilocybin session. And you'll see 6 out of the 20, so a full 30% said it was the single most spiritually significant experience of my life. The next option would be to say it was in the top 5, and you'll see that there were half of the sample endorsed that option. Now, some people who received placebo said that it was quite meaningful. That says something about placebo. I think it says something about maybe the nature of their therapeutic alliance, the music program that we use, the set and setting variables that we think are important. You know, I do want to say importantly that we were careful around instructional set. What I mean by that is we were careful to communicate to our participants, look, we don't know what your experience might be like. We know that it can vary quite a bit. Maybe it'll be very frightening. Maybe it'll be very meaningful. Maybe it'll be unnotable. We don't have any specific expectations ourselves. We're scientists. We're curious what it might be like, and we're curious if this could have an impact on your cocaine use. However, we're open to where the data is going to direct us. So I would like to think that the expectancy and demand effects here were not strong, but as Guy noted, allegiance bias is a real thing, and despite my best efforts, could have impacted our results here. So let's get to the next slide. Are you ready? These are the main results. Okay, so we're tracking percentage of abstinent days. We want to see these numbers increase with time. So at baseline, when we first see them before any treatment has been provided, you'll see that people here are reporting using about half the time on average, every other day. Usually the one limiting factor would be finances. Now during the pre-screen phase, before we've provided any treatment, you'll see that there's an increase in abstinence. This is a very common finding in clinical trials. People begin to change before you ask them to. They're very highly motivated. They had to jump through many hoops to get to where they are. They want to change, and they begin to change before you ask them to, before you begin to provide any assistance. And during the preparation phase, you'll also see that there's an increase in abstinence. So from baseline to the end of preparation, there's been a pretty dramatic increase in abstinence. And I would say that says quite a bit about the motivation of the participants, and that we're providing an empirically supported cognitive behavioral therapy. But importantly, the two lines track one another. There are no differences between the conditions until after we administer the drug. And here, your eyes tell the story. I provided some statistics, but you probably don't even need them in this case. So after drug administration, those who received psilocybin reported substantially more abstinence than those who got the placebo. There was some missing data along the way. We'd have to be careful about how we interpret the absolute rates of abstinence here. But again, I think we have a clear effect of the psilocybin intervention. But also, I'd like to say that the CBT, among other factors, also seemed to benefit those in the placebo condition. So they were doing better by day 180 than they were at baseline. I was very interested in complete abstinence as an outcome. So did anybody report, I've stopped using cocaine and I haven't had any through the final follow-up? I didn't really know how to present this visually because nobody in the placebo condition reported that outcome, but 6 of the 20 psilocybin participants said yes. I have not used any cocaine whatsoever since drug administration. I don't even really know how to compute an odds ratio. There's something called Firth's penalized logistic regression that you can use. It will produce an odds ratio, but with a huge confidence interval in this case. So the odds ratio in this case was 18.4. But the confidence interval was quite wide, so take that with a grain of salt. This is all you need to know. 6 of the 20 in the psilocybin condition said I've stopped once and for all. Nobody in the placebo condition reported that outcome. For any of you who are interested in survival analysis, so I wanted to know, after drug administration, right, was there a difference in time to first lapse among those who received psilocybin versus placebo? So even if there is a lapse, could it be that those who received psilocybin go longer before doing so? And the answer here is very much so. Hazard ratio here was 0.28. So there's a rather substantial reduced probability of lapse among those, or time to lapse among those who received the psilocybin. Now, I also want to show you outcome by participant. There's a lot going on here, but what we've tracked is each individual participant's response. Okay, and we want to know the degree to which their abstinent days have increased from baseline to the period of time after drug administration through the final follow-up. Right? So if the bars are going up, there's more abstinence after drug administration as compared to baseline. And here you can see that there were certainly some people in the placebo condition who did quite well. This speaks to their motivation. I think it also speaks to the nature of cognitive behavioral therapy. It works for some. But there were clearly more people who received psilocybin who responded well than there were those who received the placebo. The next question is the degree to which there were differences in abstinence during that preparation phase while the participants were receiving cognitive behavioral therapy, but before the drug had been administered, to the period of time after drug administration. So one question I had was essentially, any gains that were made during the cognitive behavioral therapy phase, were they maintained after drug administration? And here the story is a little more clear, right? So virtually everybody who received psilocybin reported an increase, or essentially the same degree of use for a few participants after drug administration as compared to that preparation period. But only a few, by my count 3 who received placebo, continued to maintain or increase in their abstinence. I mean, this is relevant because in almost all cases in the addiction world, once treatment is withdrawn, problems rebound. But this suggests perhaps that the effects of psilocybin could be enduring, at least in this study. Now, I don't know how much time we have. I'm looking at the clock, but that's kind of meaningless to me. Can someone give me a count? Okay, 10 minutes. All right. So I was hoping to leave some time for questions. We'll see how this goes. I'm going to switch now to talk about some of the studies that I've done here with my colleagues in Sweden. And Otto isn't here, so I'm going to embarrass him. Anybody know this guy? Okay, 1, 2, a few of you. So this is a good friend and colleague of mine. We happened to meet because one of my former undergraduate students left the US to work with Robin Carhart Harris in London at the same time that Otto was there. And Otto was interested in analyzing National Survey of Drug Use and Health data, which is US epidemiological data. And I'd done that once before. My student connected us, and we've now published together more than 20 times. Otto's a machine. He doesn't stop writing. So Otto's not here. He's in Bhutan. He's meditating on a mountain. And to embarrass him further, he'll probably never know. I have to show you some artwork that I made with Grok, because every psychedelic scientist needs a psychedelic image. And so here's Otto's. Mostly my idea to incorporate the toads. Okay, so let me Silly, I know. Let me show you some of what we did early on. So we're interested in this National Survey on Drug Use and Health data, and to determine early on, Otto was interested in the association between psychedelic use and certain health outcomes. And in 2 papers making use of this huge data set, which is publicly available, it may not be anymore with the change in our administration, but it was at least at one point. Thousands of respondents, it's all cross-sectional. We found first that psychedelic use, having ever used a psychedelic, was associated with a reduced likelihood of hypertension, and we control for all the covariates we could think of. And in another study, we found reduced association with cardiometabolic diseases. In this case, it was lower odds of heart disease and diabetes. This was really interesting. We didn't expect to find this, but it is a cross-sectional study. We control for what we can, but we're only able to control for what variables were collected. And a question to us both was whether we're really accounting for all the variables that might account for some confounding here, but also could we conduct some longitudinal studies, and also could we try our best to account for any negative outcomes associated with psychedelic use, which we realize has not been a focus in the so-called psychedelic renaissance. I don't know if any of you have noticed that, but anything you ever do, ever, is going to be associated with certain risks. And I think many people in the early days felt we are rehabilitating psychedelics' image, so we need to maybe not spend so much time talking about the adverse effects until we've sufficiently rehabilitated their image. Then we can talk about some of those adverse events. But for now, let's not emphasize that, because we wouldn't want to do anything to derail the movement, whatever that means. I don't know what that means. I haven't really ever been interested in public relations. I'm a scientist, and I'm interested in everything that can happen when someone uses a psychedelic, good and bad. So we started to look at some of the adverse effects, and it started with a study like this. And this was a study on the longitudinal associations between psychedelic use and unusual visual experiences. We used a questionnaire that Matthew Baggett in the US had developed. And in the left column are those who've reported recent use of psychedelics. I'm sorry, on the right column are those who've reported recent use of psychedelics. On the left are those who have not. And no surprise, there are a number of unusual visual experiences that people do report shortly after psychedelic use, although it's hard to say that they're necessarily negative outcomes. You'll see, for example, colors increase in brightness or intensity. It doesn't necessarily sound bad. But there clearly is an impact here of recent psychedelic use in a naturalistic setting on visual experiences, which have been labeled unusual. And psychedelic use is a strong predictor of these outcomes. This interaction term shows that it's especially more likely if you're using a psychedelic for the first time. So maybe there's some habituation to this effect. Nothing especially alarming here, but I'm just showing you the trajectory of our research together. Now, in this next study, we were very interested in the impact of psychedelic use on psychotic or manic symptoms, primarily because it has long been suggested that people with a history of bipolar disorder or psychosis should not be in these clinical trials. Matt Johnson in the back wrote these guidelines in 2008, and it's been specifically suggested that they should be excluded from participation, which does not seem like a bad idea. But what we did find in this study, this was a longitudinal study. These were of participants who were recruited through a company called Prolific Academic, designed to be representative of the US population. We found no association of psychedelic use with psychotic symptoms, but there were some associations with manic symptoms. And this seemed to be especially the case if you had either a personal history of schizophrenia or bipolar disorder. But this was what was most interesting about this to us, okay? So, exploratory analyses revealed that increases in the severity of both psychotic and manic symptoms were only observed among participants who reported psychedelic use in an illegal context. So this was the beginning of our thought that, yes, indeed, set and setting matter. It's one thing to use in a very carefully controlled setting with supportive and empathic psychologists, psychiatrists, ensuring you feel comfortable and safe. It's probably another if you're roaming about the streets of Stockholm on a high dose of LSD by yourself, right? And the idea that many of us have accepted, though not necessarily tested, as the panel had discussed, is that in the right setting, psychedelics could be very therapeutic, but in the wrong setting, they could be potentially traumatic. And this seemed to support that idea. We have more data on that here. Okay, so this is just a pretty comprehensive description of the sort of things, the sort of difficulties or distressing experiences that people can experience after using classic psychedelics, the serotonin 2A agonist psychedelics. And I'll just walk you through a couple things that I thought were quite interesting. So we first asked among people who had used psychedelics how frequently they've had difficult experiences. And you can see that for the most part, people say, never, rarely, but there were some who report regular or frequent troubles. They are a minority of those who have used, but a not insignificant minority. We asked if it impaired their ability to function, and you'll see that nearly 13% said moderately to severely, which is a bit alarming. We asked them how long the impairment lasts. Now, for most people, it would have been 1 day or less, or wouldn't have happened at all, but there were some people who reported here a few days to a week, or even longer, where the challenging experiences were impairing their functioning. The sort of symptoms that people report: anxiety, sleep difficulty, concentration difficulty, feeling disconnected, feeling distant or cut off from others, bothered by little things, headaches, body pain, some sort of re-experiencing of a stressful event in the past, some anhedonia perhaps, some sensitive hearing, other symptoms. And notably, LSD appeared to be the number one offender. In some ways that makes sense. It's the most potent. It lasts the longest. There's some dopamine activity there that might be responsible for this, who knows. And phenethylamines like mescaline were least likely to be associated with these difficult experiences. Despite all this, do note that most people would have said they were glad that they have done this, which is interesting. Maybe that's cognitive dissonance, but maybe it is the case that even very difficult experiences can ultimately be beneficial. On the right, just take note of one interesting finding, which is co-use of lithium was associated with more challenging experiences. That is also consistent with Matt's guidelines. I think it's a bad idea to use lithium and psychedelics at the same time. There's other research showing that it's associated with the increased likelihood of seizures. But most interestingly were these variables on predictors of challenging experiences, set and setting. So I think they're almost all significant here, right? Except for maybe 2 or 3. The people who said they didn't prepare for the experience had more challenging times. Those who had negative mindsets, who said they had no support, who were in a disagreeable environment of some sort, who said they took a dose that was too large or had a major life event before the experience. They all said they had much more challenging experiences, which I think supports the long-held assumption that set and setting are really important, and as Dr. Goodwin was discussing, the importance of optimizing the clinical environment to where at least our participants feel supported and comforted, and that they're in an environment where their safety is not at risk. I think I just have 2 more slides, or perhaps this is my last one, which is good. I'm good on time. 1.5 minutes. Okay. So our next study here, which we only very recently published, had to do with the longitudinal associations between naturalistic psychedelic use and changes in depression. And Guy, I don't know if you've seen this, but I'm bringing it to your attention now. So what do we find here? First, those who used psychedelics during the study period reported at baseline a higher MADRS score. But interestingly, on average, that MADRS score went up after psychedelic use. So there was actually an increase in depression over the study period among those who reported psychedelic use. That was somewhat surprising. More people who used psychedelics during this time said that their depression actually got worse relative to those who did not. So in general, we found that psychedelic use was associated with an increase in the severity of depression symptoms, something of a surprise given what we know. So we started to explore this a bit more, and without really going into the details because I don't have the time, what we found time and again was this was accounted for by use in a so-called risk context, a variable that we created based on that previous study. So if you've used in a less than ideal context, if you had a negative mindset, if something really upsetting or major life event had occurred right before using psychedelics, or if you were in an unsafe environment, your depression scores would have increased. If you did not use in such a context, we generally saw no change. But I think, again, this speaks to how important it is to use in controlled and supportive settings, but also it speaks to changes in the environment and perhaps some of the hype that has arisen around psychedelics, and certainly in the US, upon the publication of Michael Pollan's book, How to Change Your Mind. And I think those of us involved in public health communication should be careful to communicate that there's really no telling what your experience might be like outside of clinical settings, and there's a good chance you could end up feeling worse. Okay, I'm over time by 40 seconds, so I'm going to stop talking. Thank you.